Look at that hot curl on your forehead.
Yeah, like Clark Kent, man.
You good?
Oh yeah. Donald's on.
Okay, good.
Hey.
Hi.
Hi.
How you doing?
Okay. Yourself?
Good. Good.
It looks like.
Ready.
Hi, Donald.
Hey,
How
looks
are
like
you?
the captioner is on as well. Good. I mean,
Okay, oh, and screen sharing. Thank you.
We're already recording.
Yep. I'm gonna be lazy about it and just let it record. So unless I just like, you can set it up to like auto record, and it means I get like 10 minutes of like a blabber at the beginning that I have to cut off, but at least I don't forget.
Okay.
Safeguards abound everywhere.
Yeah.
Okay.
So we did 5 hours of webinars yesterday and the day before, and I'm like so zoomed out right now.
I'm so sorry. Are you at least off on Monday?
Yeah, yeah.
Good. Good. Are y'all continuing these Friday series?
Yeah, yeah. So I'll do this and then another hour-long webinar after.
Yeah, your self-advocate one.
Yeah.
Oh, can I share screen when you get a chance so I can just
yeah, let's see.
Sorry.
Let's see.
Oh, you're doing it.
Yeah, let's see. Let's see. You're getting this. Okay, yeah, all panelists. Okay. Okay, you should be able to share screen now. Okay, we're seeing the presenter view right now.
Okay, let me. Hang on,
Okay, now I'm
share.
seeing all slide.
Cool. I'm going to do it again. I'm going to swap it. 1 second. Now, you still see it. Hang on. Stop. Where did my Zoom controls go? Nope. It's not doing it. You still see my.
I'm seeing the full slide. Now we're back to presenter view.
Okay, one more time and let me make sure. Now you see
Slide.
full slide.
Yep.
You do?
Yep.
Okay, so you don't see notes.
No notes.
Okay, good. Then I will leave it alone here. Is that good, Les?
Yes. Let's take a picture.
Smile, Donald.
Smile, Donald. 1 second.
What time? It's 12:57.
No, now smile. Big ones. Donald, you got to look at the camera, not at the side. Sorry, Donald. Okay, we're done.
Good job.
I know everybody looks at the side where they think where we are, but you're supposed to look at the camera.
Yeah, you gotta, that's standard advice. You gotta look at the lens.
Yeah, it's hard.
Yeah, no, it was funny, like when last week when like Leslie was like, I need to be able to look at you in your eyes, except you're not looking at her in the eyes. You're just looking at like a bunch of
We
pixels
are.
on a screen, but it feels like you're looking somebody in the
Best I
eye.
got, baby. Best I got. Can I tell you what makes me nervous about this call, y'all, in the next 1 minute?
Yeah.
My parents registered.
No, I don't want to know this. I don't want to know this.
You know, they never see me do this, of course, because like I'm at a conference. Like it's not like let me bring my mommy and daddy, and they're so cute. You know, like 70, right? And I'm still there, just their little kid. So my mom goes, "I saw your thing on Facebook, and it's free to register. And I registered. Your father and I are going to watch it together. We only registered one person, but both of us are going to be there."
Yeah.
Okay, Mom. So now I'm not normally nervous.
So you're transported back. It's like you're doing like a what
I
I did
know.
with
I
my
told my mom
summer,
no.
or like or like.
The other piece is my dad's a doctor, and we're going to be like jamming on hospitals.
Oh yeah.
That's one of the reasons I know so much about hospitals. I grew up like that, you know. So here we go. Close.
All right, we're still good.
Okay, Katie, you saw my so I had a lot of us versus them thoughts last night.
All you see is slides, correct?
Yes, all I'm seeing is slides, but I have my notes on. I have my iPad, my presenter notes right here. Katie, you impressed?
Cool. Good.
Put my phone in airplane mode. I told my children, I said, if you're bleeding, who do you go to? They said, first we go to daddy and then we call the ambulance. I said, good.
Yeah, I'm paying my 6-year-old. Leave me alone.
Okay, I just put my phone on airplane mode. So if you text me, it'll pop up on my screen, Katie. This is fun. Katie, let's book some more work, okay?
I will be good in a second.
I watched this video of what people do to speak well at webinars, and a lot of them like jump up and down and do push-ups right now and like warm up their voice and like get jazzed. I'm like, I don't understand that. I was born energetic.
Yeah, I was watching a video about how to like perform on video, and it said you have to be like twice as energetic as you think you have to be, otherwise you seem like dull and checked out. So you need to be like really up tempo.
We're pretty up tempo, right?
Yeah.
I'll try.
Okay. I think we're at time. Do you want to get started?
Wait.
Sorry.
I
Okay.
just did. Let me make sure when I push play that it's going to be the right screen. Is it? Is it the right screen?
Yeah, you're at the title page right now.
Yep.
Okay. I lost the chat.
Oh, let's see.
Got it.
Somebody chewed me out after our last webinar for the introduction being too long, and now I'm slightly shell-shocked too. Like,
Not ours.
Oh no.
Not ours.
about my introduction being too long.
But not for our webinar, some other webinar.
Oh, is it for some other webinar?
Well, what? I didn't think ours was too long. Whatever you want to do, though.
Yeah.
We're not the chewing out type, Donald.
Yeah. It was an attendee. They sent me an email later saying, or they said in the chat.
Do they know there's a global pandemic?
Okay, I'm gonna start broadcasting. Are you guys ready?
Yeah, totally.
Okay.
Yep. Where, baby?
just a minute. Okay. Welcome, everyone. It is now 1 o'clock Eastern, time to begin. I am Donald Taylor, and I am the person responsible for special projects here at TASH. Welcome to today's presentation, Safeguards, Unprecedented Times, Advocacy, Part 2 in our two-part series presented by Katie Chandler and Leslie Lipson. This is the 5th of our webinars responding to the COVID-19 crisis. Recordings of previous webinars are available on our website at tash.org. Just click on the COVID-19 Responses and Resources banner on the main page. Check out our TASH in Action newsletter or social media notices for further upcoming webinars. For attendees who don't know us, TASH is a values and research-based advocacy association with an over 40-year history of advocating for the rights of people with disabilities. We are located in Washington, D.C., with local chapters in 18 states. Originally founded in 1975 by university researchers, we quickly expanded to include family members, self-advocates, teachers, service providers, and others dedicated to the cause of guaranteeing that people with disabilities are able to participate in all aspects of life. In addition to webinars such as this, we offer a scholarly quarterly journal, Research and Practice for Persons with Severe Disabilities, a membership magazine, Connections, a monthly email newsletter, TASH in Action, a podcast, our chapters and issue-based committees, our annual Outstanding Leadership in Disability Law Symposium and Awards Dinner honoring Judy Gran on October 7th, and our annual conference to be held this year in Baltimore, Maryland, December 3rd through 5th. You can learn more about TASH, including becoming a member or attending our annual conference at tash.org. For today's series, our presenters will speak for about 1 hour and 10 minutes, with 20 minutes at the end for questions and answers. Please notice that if you roll your mouse over the Zoom window, a menu will slide up from the bottom, and you'll have a couple of controls of interest. The first, all the way to the left, is a microphone icon. You can click on the arrow next to the microphone to get a menu to adjust your individual volume. The second button of interest is the chat button. If you need assistance during the webinar, I will be monitoring the chat box. Also, if you are in need of captioning, it is provided in a separate browser window. You can open the window by clicking the link. You can find the link in the email you received this morning to access this webinar. Additionally, I've posted the link in the chat box. Zoom has both a chat and a QA box. We will be using the Q&A box for the questions and answers. You can click on the Q&A icon to open the Q&A window and type your question there, and I will read them for the rest of participants. It can take a minute to type a question, so if one comes to you, get it in the Q&A box as soon as you can, and we'll address it when the occasion arrives. Today, we're excited to have Katie Chandler and Leslie Lipson to discuss the variety of ways people with disabilities are of increased vulnerability in the COVID-19 crisis and what we can do to reduce that vulnerability. Katie Chandler is a licensed clinical social worker who works with Shanghai University Network as a project consultant. She's a member of TASH and previously directed the Developmental Disability Program at the Georgia Advocacy Office, Georgia's Protection and Advocacy Agency. Katie uses the principles of social role valorization to support people with disabilities to have full, meaningful, inclusive lives and to teach and mentor human service professionals. Leslie Lipson is an attorney, a member of TASH, and a self-described inclusionista. She has been deeply involved in advocacy for and with people with disabilities over the past 20 years, spending the majority of her career at the Georgia Advocacy Office. Leslie found Lipson Advocacy, Education, Legal, and Strategy Specialist, where she offers advocacy solutions from a values-based foundation using general and special education law. Please join me in welcoming Katie Chandler and Leslie Lipson.
Thank you, Donald. And thanks to everyone for being a part of this second workshop in this series. So the first workshop, we really talked more, it was 2 weeks ago, it is on Tasha's YouTube, and we talked more about what people with disabilities are up against in ordinary times, and then specifically what folks are dealing with now during the pandemic, and how folks are more vulnerable and how risks are increasing, and then what we can do a little bit, and that's what we'll get more into today. Last time we also discussed distancing and more of the impact to people, as well as what you can do to take care of yourself so that you can advocate. And then today we'll look specifically at some of these dangerous assumptions that get made about people with disabilities, and then the vulnerabilities that come from the assumptions, and specifically what vulnerabilities that we want to address right now as we're thinking about how we can safeguard and stand by people and make sure that folks are informed and have what they need if they do need treatment in a hospital setting or some sort of medical treatment, as well as just the increasing risk for people being more isolated, and just what's going on in the current stage right now. So, and towards the end, we'll get into some remedies, maybe some potential advocacy strategies, some ideas that you can use. First, let's see, we're going to do a poll because we like to know who's joining us. And Donald's going to launch this poll. So if you will check all of these that apply. So if you're a person with a disability or a family member, if you're a TASH member, please check that, a direct support professional, a service provider, an educator, possibly an employee at an advocacy organization or a community advocate, or in some other role. Okay, thanks. We just saw a comment that it's only letting you choose one role this time for this poll. So pick one and we will see those results. Okay, great. Welcome everyone. We have a great mix of folks participating today and look forward to discussing with you. So when we're thinking about safeguarding, people need safeguards all the time, right? Everyone, not just folks with disabilities or folks who are potentially more vulnerable, but we all live with safeguards that help keep us safe in our ordinary activities. But even more so now, given the increased risk with greater isolation and the fact that many people with disabilities that we care about are living in segregated, congregated settings, we know the real risk in those places, and as well as the very dangerous assumption we'll discuss that people are seen as not having a life worth living. And so as we're talking about safeguarding, and particularly medical safeguarding, this quote here from Michael Kendrick speaks volumes. And we've highlighted this piece in yellow that I'll read out. And Michael says, with vulnerable people, particularly those who may be unwanted, socially devalued, and otherwise outcast or even abandoned, we do not have the luxury of such a degree of perfectionism about safeguards that we do nothing until we can do everything. And so this speaks to us because we want to make sure that we cover the fact that most of what we're talking about today, you already do, you already know how to do. You will tap into all of your advocacy tools that you've learned throughout the years as you're thinking about how to stand by people and how to make sure folks have what they need. And this quote, "Don't let perfect be the enemy of good," speaks to us as well, because we just want to make sure that folks don't think that they can't do anything until one can do everything, that we're still striving for, with the most effort to offer the most protection, and that our safeguarding response has to meet what people are up against. So it really has to address the vulnerability and address those assumptions and the stereotypes and what people are up against in this potent response. So towards the end, we'll be talking about these resources and these responses. This is a list that we covered just briefly last time, and we've added to and tweaked a little bit so that we can discuss together what it is right now that's more problematic, these dangerous assumptions that get made about people with disabilities. And so we're going to go through this list, and then we'll have examples for each of them. But in people with disabilities, folks often assume, and we're talking about society in general, not your personal beliefs or assumptions, but in general, people with disabilities in our society are seen as a burden on families, sometimes service providers, healthcare system, and society in general. People get seen as a burden. An assumption gets made that people, especially now when we're hearing the words hazard pay, the idea that people are hazardous to work with. And that's a dangerous assumption because it attaches to the person, and then that stereotype gets reinforced that people are hazardous or contagious or needed to be staying away from. Another dangerous assumption is that people are not competent to make decisions and that people are in need of being protected. And this usually shows up in a way of overprotecting people. And by overprotecting people, what we're noticing is that folks are really uninformed and folks are missing important details about what's going on because someone's intent is to protect a person, to make sure that they don't cause more stress or anxiety, but that can also create the impact that folks really are uninformed, and that in and of itself can create more stress and anxiety if folks don't know what's going on. So folks being assumed to not be able to make their own decisions and to be overprotected. Another assumption that we see, and these next two go together really, is that people belong in group homes and facilities, that people with disabilities, there's a special place for folks with disabilities. There's a separate world that exists with specialized services for people with disabilities. And so this assumption actually gets strengthened because these certain places do exist, that folks belong in group homes and facilities, which is also the idea that people with disabilities prefer to be mostly with other people with disabilities. And while that may be true at times, it's not true for every person all of the time, right? People would prefer to be with a mix of people, of folks that they have relationships with, and not only just people with disabilities. So that's a dangerous assumption. The next one is the idea that people are seen as being unemployable and incapable. So folks with disabilities are not seen as being able to work. And if they are working, we know that many folks are not being paid a fair living wage. And then also many folks who are not working are spending time in programs throughout the days where it can be, and I've visited numbers of these, where it can be that folks' potential isn't recognized, isn't addressed, that is doing some things that might not be most meaningful, and that sort of stuff. So these are dangerous assumptions as well. The last two that we'll spend the most time talking about later today is the fact that folks are seen as undeserving of medical treatment. They're being denied medical treatment, and the assumption that folks lack a quality of life, they don't have a good quality of life, or they don't have lives worth living.
So to kind of encapsulate what we were talking about, is these really generally are assumptions that exist for people with disabilities across lifespan, across history, things that people with disabilities, assumptions that are made about them all the time. But during COVID, these things are even more dangerous. We have to be more aggressive about pushing back against them and more thoughtful. And this is one thing we really want you to hold true, is the idea that whatever is the intent, it is the impact that matters. So many policies we're going to talk about today, especially around medical safeguarding, the people who have made these decisions have really good intent. But the impact to people with disabilities and the people that love them is pretty significant. Additionally, we could spend a lot of time explaining why certain policies exist or why the need for advocacy exists, but that's not today's session. And I do promise to Zoe Allen Lewis that we will hit our time frame. We will be done at 2:30, promise. But we're going to spend a lot of time thinking about what the impact to people is and not why they exist. Another webinar is why they exist, but we really want to focus on what the real impact is to people with disabilities. We're going to show you some examples of the things Katie has discussed up until this point. Next. So Katie already spoke to the idea of burden. We want to show you a recent example next. This is a headline we just pulled a couple days ago, May 13th, the extra burden for parents of children with special needs. The idea being that kids with disabilities in society's eyes are always a burden, but they're an extra burden during COVID. As the parent of children with disabilities. Parenting in and of itself is a whole lot of work. But the burden does not exist with in my children. There may be a burden in trying to navigate systems that are massively inhospitable and at times hostile. But children themselves are not the burden. Next. Hazardous to work with. Next. The idea, so hazard pay. So we're not saying that people who support other people with disabilities don't deserve an extra bonus or an extra incentive or extra pay during this time where the work is particularly important, where we're afraid about a very contagious pandemic, where people need to learn to use protective gear and wear extra stuff and maybe need more training and have to do more cleaning. All of these things deserve some extra money. We're into that. But the idea of calling it hazard pay and imaging people with disabilities as hazardous and working with people with disability and working with people kind of casts people, or it does cast people in the idea that people are menace and they're dangerous. And this really reinforces a lot of people's ideas of who people with disabilities are. Again, this is not what Katie and I think people with disabilities are. This is the culture. You could say in America, but really the culture in Western locations. Next, the idea that people are not competent. Can you hear that?
Yes.
You take the next two and I'll handle that, okay?
Okay, sure. So that folks are not competent to make decisions and in need of being protected. I spoke of this just a little bit ago, and the idea that it really shows up in people being overprotected and people not maybe learning competencies and having a lot of practice with making decisions. And so the reliance on other people to make decisions just gets reinforced, and then it continues to be an assumption that gets made about people. Folks belonging in group homes and facilities and preferring to be mostly with other people with disabilities. We know what's going on right now in all of these type of places where folks are segregated and congregated, living together and at much higher risk of being exposed to COVID-19. And then what happens after that with whether or not people are going to be treated. But really the exposure just of these places is where most of the cases are, in nursing facilities and institutions, in our prison system where folks are congregated and segregated. And so the assumption that people want to be only with folks with disabilities, or that people belong in facilities like this, is very dangerous and risky, because we know what happens when folks are in these, if they're not safer.
Are we unemployed and incapable? So many people assume unemployability about people with disabilities. In the current COVID world that we live in, the rates of unemployment are skyrocketing. And many people think that that isn't particularly impactful for people with disabilities, and that they already don't really work very much. And so that's a very dangerous assumption. Additionally, people with disabilities are often thought of being incapable of making decisions around healthcare, around their life, around their sexuality. And that this becomes evident in people being massively overprotected. And this is also a big risk during the COVID time. Next, the idea that people are undeserving of medical treatment, and that people don't have a life worth living. These are tightly connected to each other, that people don't have a life worth living and therefore are not worth having medical care. This example of a headline from the New York Times is, how do hospitals decide who gets treatment? For people who worked in this field and people in the medical field for many years, we know that healthcare has been rationed over time, and that there are many people with disabilities that do not get life-saving treatment because of their disability. Interestingly, it hasn't been front page news, and in that way we're more happy, not happy, we are encouraged by the raise of consciousness of other people that there is medical rationing going on. But it's particularly dangerous because it can make you dead if you were decided to be a person that isn't worth treatment. Additionally, if the idea that your life isn't a life worth saving, your life isn't a life worth living. And we know that when people start talking about quality of life, that the next assumptions are about whose life is worthy. We see this. Time magazine recently read an article. This is really life or death, but people with disabilities, coronavirus is making it harder than ever to receive care. So this is not only about the existence of COVID in and of itself. Like maybe you'll get it, maybe you'll need hospital or you'll need care. It's not about that alone. It's about the idea that other routine care or other typical supports are even harder to get during this time of the pandemic. And that particularly is dangerous. And people with disabilities are at disadvantage when scarce medical resources are being allocated. We have across the nation and across the world documents called triage documents, where when a hospital staff sit down, medical staff sit down to decide who's going to get the care, they list out certain qualities that make it more likely people will get care and certain qualities that make it less likely people will get appropriate medical care. And disability has showed up over and over and over again on these triage documents, as is people who are elderly, and elderly can be what we would not consider elderly, so anywhere over the age of 60 in some countries, 70 in other countries. So we're not saying this is new. It's happened before the time of COVID, but it's definitely more intense right now. So we believe, what we believe is what we see. Our mindset and how we look about and think about advocacy really matters. What we observe, and for many people who maybe have a very distant relationship with people with disabilities and are not aware of the disability civil rights movement, are not in relationship with people with disabilities, are thinking about justice and equity and civil rights, for many people, the list that we just went through is getting more reinforced during the times of COVID. The idea that people with disabilities are, right on the edge of being ready to die, that people don't have a life worth living. And so we need to be really careful about our mindset and how we think about it, because we believe what we see and we see what we're looking for. So we really need to be highly conscious about this idea.
And to use it in our advocacy once we have the understanding and the belief of what society's assumptions are, so that we can push back on those, because that would be what other folks' mindsets would be. Like, these assumptions create the mindsets, and then from that create the actions. And so that's where we'll need our advocacy, is to push back against these assumptions and the actions that get created out of what people believe about folks with disabilities.
And next, so it's not just about our mindset, and it's not just about our action. It's not just about our thoughts, but this idea from Ralph Waldo Emerson: your actions speak so loud, I cannot hear what you are saying. People move their mouth and things come out of their mouth. You read pamphlets by organizations, what they say they do. People talk about, what their services are like. And then when you start to lift the veil and look and see what it is, people's actions don't match their words. But usually their actions are a reflection of their mindset. So we really want to carefully align our mindset, our words, and our actions, and make them very coherent. And when they're incoherent, when you hear these discrepancies, these are the places where advocacy is really needed.
So the list on the left side of the screen is the list of the assumptions that we just went over. And then we created the list on the right side, which are the vulnerabilities that are there because these assumptions exist. So because people are seen as a burden, or people are seen as hazardous, or people are not competent, then the vulnerabilities that are there within what that means for folks is that folks are surrounded mostly or solely by paid supporters. People are lacking relationships. That's a vulnerability. Another vulnerability is that people are pitied, people are mistreated, people are subjected to abuse and neglect. People are seen as being contagious or a menace to society, as Leslie described. Another vulnerability is that people are uninformed, and many folks quite familiar with other people having control over their autonomy and their freedom, quite familiar with other folks determining, their daily lifestyle, like what they do during the day and what time those things are and who they can be with during the day, and all those kinds of little details to whether or not folks can work or whether or not folks can go certain places or whether or not folks can have certain people spend the night, and all sorts of things that folks, many folks, become sort of compliant because so many people have had control over their lives for so long. The vulnerability, we spoke about how people are segregated and congregated, and that people are at much more risk living in group homes and facilities. And a true vulnerability that comes out of these dangerous assumptions, and this is not just during COVID, but it's more so during COVID, is that people are isolated, for people lack relationships, and people are lonely. Also, people are not contributing or enhancing their competencies is a vulnerability. That's a risk right now, that people are not having meaningful things to do to contribute to their communities, to society, to their families, or in whatever way that people are not contributing right now, or are not enhancing their competencies, learning new skills, practicing new things, and those sorts of things. The last two vulnerabilities that come out of people being seen or assumed not to deserve medical treatment, or to be discardable or disposable, or to not have a life worth living, is that people are denied the medical treatment, and that people are seen as better off dead. And so it's with this list of vulnerabilities that we'll spend the rest of our time together on these specific ones we pulled out. And the three that are highlighted at the bottom are where we'll spend the majority of our time. We'll just talk briefly about the fact that the vulnerability when people are uninformed and familiar with other folks having control over their autonomy and freedom. What can we do right now? What can we do when people are more so isolated and lonely? And what are some ideas to address the vulnerability of people not contributing right now or enhancing their competencies? And then finally, to address the vulnerability of folks being denied medical treatment, folks potentially being unaccompanied in the hospital if they need medical treatment, and folks being seen as better off dead. That is where we will get.
And so the way that Katie and I were brought up to think about this, it's something we find really helpful, and we hope that you'll find helpful. And I want to tell you that I find this way of thinking way more helpful than anything I learned in law school. This really is powerful for helping stand beside people with disabilities all the time. So you think about a vulnerability. You have to really clarify what the vulnerability is. And the list we gave you is not exhaustive. There are a lot more vulnerabilities, but those are some of the most frequently seen. You take that vulnerability and then you generate a bunch of different advocacy strategies. One thing I really love about advocacy is there is not the right answer. There are so many answers, right? You can look to legal advocacy, to citizen advocacy, to policy work. You can write letters, you can write op-eds in the newspaper, you can get together with other organizations and write letters. You can talk to somebody in power. I mean, we could generate for days all the different possible advocacy strategies, and that's something that we really enjoy generating. But that's one way. It's like when something bad happens, what are you going to do? Another way to think about things is safeguarding against the vulnerability. So picking the vulnerability and thinking about what are all the different practices we can put in place to make it, we can't guarantee it, but to make it less likely that that vulnerability will become particularly problematic. And we build those in all over the place. Next is the idea of remedies. And remedies, as a lawyer, I have to tell you, are limited. They're so limited. The idea that any type of remedy actually ever makes you whole. People that experience trauma, people that experience abuse and neglect, people that experience trauma through the medical system, or people that have been rejected by human services, all the different reasons you would seek a remedy that you've been harmed. It's hard to find a remedy that really makes you whole, because we're people, we're not like widgets. But still, advocacy and legal advocacy and practical advocacy does offer remedies, things to try to make right what has gone wrong. And so this is the framework that we're going to use to talk about safeguarding in the time of COVID. So Michael Kendrick is a mentor of both Katie and mine, and probably many people on this call may have heard his name. If you haven't, you should definitely go take a look at some of his writing on safeguards. And I'm going to read this definition out loud because I think it's that powerful. Intentional safeguards can be thought of as conscious. They're not accidental, they're conscious design or practical features that can be variably be added on, built in, or strengthened in order to preserve or enhance something of value in a situation and thereby better manage the vulnerabilities of people and situations. So number one, you have to value what you safeguard, right? Nobody takes, a stick of butter and puts it in a lockbox, a safe. We put money or diamonds or guns, or, whatever you value, you're going to put in a safe. You want to safeguard the things that you value. So people that you value or systems that people value are likely to have better safeguards. And people that experience devaluation and that live in devalued status, and certain whole entire bureaucracies or systems that are devalued, or certain groups of people that are devalued, will experience less safeguarding. For example, direct service providers and workers also experience devaluation, much like people with disabilities, and they haven't had good access to protective gear the way we think that people should as a safeguard during this time. That'd be a good example of a safeguard that we hadn't really thought of pre-pandemic, would be the use of masks and other type of protective equipment. Next. So let's think about this, a vulnerability, that people are uninformed and familiar with others having control over autonomy and freedom. So now that I look at this, we might have written it a little clearer, but the idea is that people are uninformed about COVID. We've met people that live in institutions and group homes and places where they haven't had a lot of contact with the outside world, and they know that something's going on because they're not getting out much, but people really aren't aware of what is COVID-19. Why is hand washing important? What is going on? What's going on, kind of legally in the culture, in the world, and people really need to understand what it is in order to keep yourself safe. Additionally, many people are really familiar with this vulnerability of having people tell them when to go out, who to see, where to live, when to move, all of these different kind of control that happens in people with disabilities life. And that way, this whole stay at home, shelter in place, quarantine thing, being told where to go and what to do, doesn't feel so unusual. So it makes people really vulnerable, even more control. So some of the remedies and safeguards we thought about is making sure that people are not only aware of the safeguarding strategies and what's going on in the culture, but people are prepared and good and ready for it. So our next particular slide, we did a presentation 2 weeks ago. Check out the YouTube. I can't watch it because my voice squeaks to me, but you could watch it. But this, we were talking about wearing masks, and that people really need to get used to wearing masks, and that whoever you love with a disability, any sensory issues, any reasons that people think they can't wear masks, we have to get people really used to them. And somebody from the Department of Behavioral and Developmental Disabilities in Georgia, who was very helpful and sent Katie and I this document that they've created to help people understand masks, why you wear them, what it's about, and how to make masks seem less scary and more comfortable. And so we just thought it's in your handouts, but we thought this was a really nice idea. So point being, you have to be conscientious about it. You can't hand somebody a mask and be like, here, you're good to go. You wear a mask now. People might need to be prepped and understood, like, why are we wearing a mask? How do we wear a mask? Where do we wear a mask? How do I pick one that's comfortable? Where do I keep it? How many do I need? All of these things. Okay, next.
Yes, there are lots of resources available for self-advocates to become informed and to learn more about the current pandemic and what folks can do. And there are a couple here that will lead you to many, many more on the Self-Advocacy Resource and Technical Assistance Center website and Green Mountain Self-Advocates website are two that have a wealth of information and different articles and videos and documents that really lead you through, written in user-friendly language, written in clear need-to-know information that will really support folks to understand kind of what's going on and what you can do during this time. There's one specifically that the groups wrote for working with your support staff during this time. So there's a guide on that. There's a glossary around words that are now being talked about during the pandemic. So, I mean, it would be defined pandemic, and social distancing is defined, and what is coronavirus, and all of these specific words being defined in this way will help folks to get more informed. And so we would encourage you to check these out and to share them widely. The next slide is a video that we found that was put together by Quillo. And this happened after someone had described to the gentleman who runs this agency that this person went to the hospital or went to see a doctor and didn't understand why the doctor looked different than how the doctors always look with all the protective gear. And so we're going to show this. It's less than 2 minutes. It's just a quick little video that we thought Quillo did a really great job of putting together and that could be shared with self-advocates.
We don't have the audio.
Oh, sorry. Wait 1 sec, guys. Oh, no. Okay, let me.
When you go to share it in Zoom, there's a little checkbox that says optimize for audio.
Right, it's in my ears. That's why.
I hope you're feeling well today.
Oh, no, and I just had it and my finger hit it. Okay, last time, guys, sorry.
I hope you're feeling well today, but if you do need to see a doctor, some things have changed due to COVID-19. First of all, you may talk to a doctor or a nurse over the phone or by video to talk about how you're feeling. If you have someone that helps you with your healthcare, invite them to be on that call with you. If you have to go to see the doctor in person, things have changed there too. You're used to seeing the doctor or nurse like this. Now, to keep you safe, your doctor and nurse may be wearing a lot of coverings. It makes it seem very different when you can't see their smiling face. But you should know it is the same nice person underneath all of this. So don't worry. They may look different, but they are there to help you. Doctors and nurses see a lot of people every day, and some may be very sick. So to keep everybody safe, including you, they have to protect you by wearing all this gear. Remember, they are people like you who want you to feel better. Stay safe, and we hope you get to feeling better soon.
So that was just, we thought, a very well put together description that if folks are fearful or uncertain before having any sort of medical treatment, that they could watch that and have a little more understanding.
So the vulnerability that people are denied medical treatment and seen as better off dead. What can we do around this enormous vulnerability? The first thing always is to be really informed about the healthcare system. The other second thing we're going to talk about, actually a couple more things we're going to talk about, is to know rights and strategies for increasing identification between a person with a disability and the people who are providing the care and the decision makers about who's providing care. Okay, so the next slide. One of the things we want to understand is in ordinary times, the stressors, the barriers, and the challenges that we currently have in our healthcare system in America. And this probably, if you're listening from another country, might in some ways be similar to other countries. In some ways, I think America is very different, our healthcare system, than other countries. I think it's pretty common in the West that's based on the medical model. The idea being that you are sick, you go and interface with the healthcare system and people cure you or make you immediately well. This is very much in tension with the ideas that many people with psychiatric disabilities are living in recovery. Many people with chronic disabilities are currently still living with chronic disabilities and chronic conditions, but they're managing it, but it's not a cure. So that's the medical model. Healthcare and the provision of medical services is not an exact science. I can't remember a time within the popular consciousness, the idea that we understood that doctors and medical professionals don't know everything, especially during this time of COVID, because the information coming out is new all the time. It's not an exact science. And in the same way, the healthcare industry is run by humans, and humans are fallible and they make mistakes. And within healthcare settings, there are many mistakes made. Going back to our earlier slide, it's not about intent. We don't think people intend to hurt other people or intend to make mistakes. It's about impact. And it does happen. And you have to know that. Because once you realize that the mistakes do happen, you become more vigilant looking for them and making sure that you're really conscious of it. Within our culture, we have racism, ableism, ageism, homophobia, xenophobia. All of these things that exist in our culture also exist within healthcare. It's not some sort of, land where all of these things don't intersperse. And some of the data we have data, strong data on all of those indicators. The healthcare system has many players. If you've ever had a loved one that's in a hospital or that is inpatient at a facility, and you're trying to figure out who to talk to solve a particular problem, it's really confusing. You can get an organizational chart and still not figure out who you're supposed to talk to. There are a lot of people in charge of a lot of different things and a lot of different units, and it's confusing. The other piece is it's big bureaucracy. I know many people would blame the lawyers for lots and lots of protocols and lots of things being written, but there are many reasons they're big bureaucracies, but they've only gotten bigger over time. It's full of barriers for people accessing care and appropriate treatment. You can worry about if you're actually going to get health care. And then once you receive the health care, if you can get it, you can be very worried about if you can afford it. Many bankruptcies are filed every year in America because of people's healthcare expenses. Additionally, healthcare has become more expensive than other indices. Like you'd expect healthcare to be 3% more expensive a year, and it's way more than that. That's not the exact number, but the idea that healthcare has become more and more expensive disproportionately to other expenses over time. Many people are uninsured. This is in ordinary times. In ordinary times, many people in America are uninsured. Additionally, there are a lot of conflicts of interest within the healthcare system between patients, between stakeholders, between industries that operate healthcare systems, best practices, between government. I actually saw a friend last night whose husband works at a big hospital where I live. And he said that they were doing telemedicine in the times of Corona to keep him and his patients safe. And that because there was a certain facility fee that they couldn't charge within the telemedicine, the hospital was losing millions of dollars a day. And now they're not seeing telemedicine anymore in order to connect to the facility fee because they're still paying for the facilities. And he was distressed because he felt like he was endangering his patients, having them come in if it could be a telemedicine appointment. And it was such a good example of a very kind of common tension in the way we provide healthcare. Additionally, healthcare systems and getting healthcare can be dangerous. If you've hung around anybody with children, mothers and children lately, and fathers too, but I said it many times to my children, don't do that. We're not going to the emergency room. Like we know that like right now and always, hospitals can be dangerous places. You can get amazing care, but also there are certain types of illnesses or contagious diseases always in hospitals you can get, and that mistakes do happen. So with these things in mind, next.
We were just laying a little bit of framework to understand the medical system in general as we go into what it is that we can do, what some of our safeguarding ideas are, what some of our advocacy strategies, and some potential remedies that you can explore. And this quote here comes from a booklet that Tom Kohler wrote entitled Protecting People While They're in the Hospital. And it's got a lot of excellent information in it. And this quote, the most important protective measure for people in hospitals is mindset. Be proactive, be intentional, be protective, and be intense. And so if you do have a loved one who ends up needing to be hospitalized during this time with coronavirus, the most important thing you can do is around your mindset and then your advocacy skills to try and shape the mindsets of the other people who are providing the care. Because our beliefs and our assumptions make up our mindset, and then our mindset shapes our actions. And so what we don't want is for the folks who are providing the care to hold all of the assumptions that we talked about earlier that increase the vulnerabilities to people with disabilities. And so what we can do, we'll talk about next, are some of the things, ways that we can be proactive and intentional, protective, and very intense to advocate with urgency. There are several different versions and options of forms that will collect information about a person. We've got 3 here to show that give, you know, specific details that could be filled out now before anyone might ever need to seek medical treatment in a hospital due to COVID-19. Because when that does happen, if that happens, and we hope that it doesn't, but if that happens, folks aren't going to be in a clear mindset to be able to provide all this information. And so this is something that folks can do to be proactive, to get prepared just in case, right? And so this first tool was with the health risk screening tool, and I pulled it out because it asks lots of different information about how a person communicates, and then what supports are needed specifically, as well as medical information. So there's a phrase that says, when I like something, I express it by, or my usual sleep pattern is. I usually interact with strangers in this way. And so if the person and loved ones, someone who knows the person really well, were to put some time into completing something like this, it doesn't have to be this form, but something where it's written down and easily accessible when you need it, if you need it, hopefully not, that could be very helpful for the folks who are now treating the person or now getting to know the person. Would be able to look to this and say, like, oh, so this person said that when they're angry, they sometimes, and then it would be just the description of what it is. The one that Green Mountain Self Advocates created has, you know, a very clear way to describe how a person communicates. And let's say that the person is alone, and if the medical provider does not understand, it's got phone numbers and names of people that they can call and reach rather quickly. So that's a protection there, that just in case somebody's misunderstood, that they can reach out to somebody who knows the person really well. Talks about how a person's typical reaction is. And then this one was developed by Dr. Ballin at State University of New York. You may have already seen these. They have been around for the last couple months, and we just thought they were a great tool to use as a safeguard and to get prepared. And so this link here that is in your handouts takes you to the map of the US, and it has a different form for each state that's specific to, you know, tweaked for each different state, so that you could get the one that applies to you if you wanted to complete one of these.
So let's talk about what Katie's run through so far is the idea that, like, let's say you're at home and you have a 33-year-old son that lives with you. You are married to somebody who has a disability. You have a 13-year-old daughter who lives with you that has a disability. And you are worried, as I think we're all worried about our loved ones. What if they get COVID and they need medical treatment, and I'm advocating for their medical treatment? And there are 2 or 3 things, maybe. Let's talk about 2 first, that go through people's mind. The first idea would be, well, will they actually get treatment? This idea of these medical triage, will people get high quality, appropriate treatment? And that's a huge issue. So one thing that TASH has done so beautifully is they authored a document, a letter, with many other organizations, I think 110 organizations, a joint position statement on, in the time of COVID, the idea that people can use supported decision-making, that they have access to information in the hospital that's plain language, that has visuals. You know, you can't really have informed consent about medical treatment if you don't understand what's going on. So additionally, these things should be in the language that people use for communication. People should be able to receive supports and services from a supporter that knows them. Have the right to decide what to do in a crisis, that people retain their autonomy during this time. And people have accommodations they need to make particular decisions. And they have the right to have somebody with them, even when they have COVID within the hospital. And this is an early, not early, but it's an early advocacy action in the time of COVID, taken on by our organization TASH and its comrades to make sure that people have access to medical treatment. Next, the federal government, the Office of Civil Rights, came out on March 28th with an official bulletin that says that people with disabilities should not be denied medical care based on stereotypes. Assessments of the quality of life are judgment about a person's worth based on the presence or the absence of disability. And this is very important, that the federal government came out and said this exact piece. It pushes against medical rationing. And if you took your loved one or you were a person with a disability and somebody said, well, you know, we are going to deny you this particular ventilator or this particular treatment because you have a disability, it's very important to have this kind of document that protects people's rights to actually receive medical care. Another place that we were really impressed, we found just so many great materials to help families and to help people with disabilities advocate for themselves, is this website and this whole campaign, No Body is Disposable. It really pushes against one of the ideas we talked about earlier, the assumptions about people with disabilities, that people with disabilities are disposable. They have a really wonderful toolkit. Can you go to the next slide? That what to do before needing to go to the hospital. And so there's a fair amount of information you can do before you go to hospital. And listen, it's up to each family, like how much you need to prepare, you know, like I think it's hard to know like when you need to prepare, how much you need to prepare, what will make people anxious in your family to prepare, how you figure that out. Critical legal documents. It has specific things about people who have higher weights, making sure that people who have a lot of body weight are also protected and get appropriate medical care, strategies for advocacy. And if you face discrimination, what can you do about it? It also has really excellent sample letters and template letters for people. And you can also contact them. I was really impressed with this particular website. And I think you should also take a look at it.
So with these tools, they could certainly help you to feel, you know, a little more ready, just in the case that someone does need to go to the hospital. You would have some things in your pocket, right? Some things already written down about how people communicate and what it is that they need to be supported. Have some details listed out, as well as the letters that Leslie shared with the position paper and the Office of Civil Rights document that, you know, really describes. The other ones, you can go through all of those tools on that website. So here's another quote from Tom that we found very compelling. And it says that there are many different reasons you should personally protect your friends and loved ones in the hospital today. You may not be a professional or an expert, but you are there for just one person and for just one reason. Common sense and concern go a long way towards helping in almost any situation. And we believe, as we said at the beginning of this, that you already know how to do this advocacy. You know how to be urgent and to come up with some potent strategies to make sure that your loved one or that you yourself get the best care, and who to call in for reinforcements, who to call in to like help you advocate when that's needed. But it's to say that you do not have to be a medical professional, you do not have to be any sort of expert, not an attorney or a social worker or any sort of person with any sort of, you know, that sort of professional title. You can advocate for yourself and use a lot of the tools that we've already presented to get your allies and supporters lined up to be able to do so with you. So common sense and concern go a long way towards helping in almost any situation. You're there for just one person and for just one reason.
So recently, this incredible document, Katie and I read it like over and over and over again, went back to each other, was like, this is really helpful. It is really helpful. I encourage you to go look at this. It was just issued on May 15th. All of these really amazing organizations at the top of the slide, I'm not going to read them, were involved in this evaluation process. So let's go back in time. When you first heard about COVID and when people were in the hospital who had COVID, you would hear, well, they're going to be alone. Nobody's going to be with them. Because the idea initially often was that, especially like, let's say late March, early April was that people couldn't have visitors because you didn't want to expose any more people to COVID. So a couple different ideas. One idea is you couldn't have a visitor. You couldn't have somebody with you. And we even heard this in relation to like labor and delivery, that like if you were going to have a baby, you might not have anybody with you. A lot of that has changed, and people are allowed to have visitors, no visitors. But you know what? We're really not talking about visitors. We're not saying that people really need visitors. We're saying people really need supporters. They need an advocate. They need an ally. So this is really an evaluation tool to look at what are hospitals offering somebody who is experiencing COVID, and this is particularly with a disability, their supporter when they're there with them. Are they allowed to be with them? How are people keeping people safe? So this is a guidance document that the first couple pages is all the law stuff. If you like the law stuff, take a look at that. It's, you know, it's good, it's fine. But the last couple pages are amazing. It's like 13 or 14 different frameworks for looking at the visitor policies and what are the things that are important. And really, it really hits communication beautifully. The idea that people aren't communicating with people in the way they know how to communicate, whether it be a communication board or whether it be sign language or whether it be understanding people's grunts and sounds and whatever people are putting out there, that somebody needs to be there to translate and make sure that that's understood. And I think we would all deeply relate to that on a human level, that you'd want somebody with you that could do that for you. So next, going back to this idea, who do you want and who can stand beside you when you need medical treatment and to be for medical safeguarding? And this is during the time of COVID and not during the time of COVID. And these are some qualities that just are pretty fabulous. And Kitty's already discussed this, and that like you don't need to have a professional degree after your name. You are enough the way you are right now, especially if you've come and listened to this webinar. You're way more than you would have been, right? And you really already have these skills. You need courage and fortitude. Asking people in white coats lots of questions on kind of peering in and like saying, so what about this and what about that? And I read this, and you know, you need a lot of courage. That can be really hard to do. Stick-to-itness and persistence. I think in the time of COVID, this is even harder. Before COVID, like you could switch out, like I'll take the morning and you take the afternoon and so-and-so will take the night and so-and-so will bring us food, and you could kind of switch out. Now they're really asking people to pick 1 or 2 or 3 supporters, and people also, when they do get COVID, are oftentimes in the hospital for a very long time. It's not necessarily a shorter stint. So you need a lot of determination. You need to really know the person and know them well. That's always true. Diplomacy. Our healthcare providers are under so much stress. And, you know, people have a bad day, they're cranky. And for many people who are providing healthcare right now, it's a very challenging time that has nothing to do with the people receiving care, but people may be extra cranky and you may need to be extra diplomatic. Courtesy, you know, making sure that you're not in the way and you're not making it any harder for the person to receive care. We always need a sense of humor. Practical knowledge of medical and personal care. So understanding who is the charge nurse, how does the floor work, when do rounds happen, when can you ask the questions, who do you ask questions to, how do you get a second opinion, how do you navigate insurance? Like you understand these things, and I have to tell you, a lot of times when I don't understand these things, I go to the Google. So part of it is being willing to like research and go back through it. And then Tom Kohler, he's from Georgia, if we haven't introduced him. This last sentence just gets me every time. A habit of quiet skepticism mixed with an honest willingness and ability to step up and step forward on behalf of a person. You have to really have a balance, and these things are more important now than ever. So this author wrote the book Kitchen Table Wisdom, which is a book that I really love, really speaks to me. If you have extra time, take a read. Fixing and helping create a distance between people. Fixing and helping create a distance between people, but we cannot serve at a distance. We can only serve to which we are profoundly connected. So not only does the supporter need to be connected to the person with a disability who is in the hospital, but that person needs to serve to connect the person receiving treatment, receiving care, to the people providing the care. So you really need to role cast people and make sure that people know who someone is. So that if somebody that you love is an employee at a bookstore, is a beloved brother and friend, happens to run a lot of the errands in the family, also is a great traveler, then maybe you have pictures of some of these different roles on the wall near somebody, that you talk about the person in that way, that you serve to make sure that the people that are providing the medical services understand who this person is, that they are a beloved member of their community and family and all the other pieces that you would know, and to make sure that people are connected, because this is really important to make sure that you're receiving really good care.
So this resource that's in front of you, Leslie, I think, sent me a text message a couple of weeks ago and said, if I watch anything, I need to watch this. This is the best information that both of us now admit that we have found around supporting people and protecting people and safeguarding while folks are in the hospital, and what you can do. It is, so the link is in your handouts, developed by Gina Stephen, and it has so many tools and tips and guidance. She is I think a sibling and also a parent of a person with a disability, and really knows the healthcare system and really knows advocacy. And so some of the favorite things we've already discussed because many of you are already doing them, but she talks about preparing the story, writing it out before a loved one needs any sort of care in a hospital, making sure that you come up with your points in advance if you're asked to leave, if you're denied being able to stay with your loved one, to be able to describe exactly what will happen and how the person's going to be at greater risk if you are denied being able to be with the person in the room. So with very specific guidance on exactly what will happen. Like if there's a time that you can point back to when this may have happened before and say, this is what occurred when I was asked to leave or when I couldn't get there in time, with to be able to have this written out, for prepared, at least thought of in your mind before this ever happens, if it does, hopefully not, so that when you're in that stressful situation that you have it to be able to deliver. She talks about understanding the rules in the healthcare system that you're a part of right now. One reason people are being denied access to be with a person is because of the lack of PPE. So she suggests bring your own and show that you are willing to comply with the safeguards that the hospital has established to keep all the patients and the visitors who are allowed to be there and the personnel safe and secure. So be willing to do that. Make sure that you get to know the folks who are providing care. Like Leslie said, you know, to be diplomatic and to offer some courtesy, but even to go, you know, with your welcome and hospitality, once a person is there and in the room, just to pay attention to who people are as best you can, so that they're seen, so that they will see you and your loved one as well, because it could go both ways, right? You want to increase the interpersonal identification between the workers and the person who's receiving care, and make sure that they have that the workers see what's good about the person, who the person is when they're not actually sick in a hospital, what the person offers in their community, offers to their family, so that they can see some of these things and really get a sense of who the person is. Those are some of the takeaways that I have. I think Leslie had a couple more too. She has have your allies and advocates like on, you know who you're going to call if this time comes. Like have that thought out.
One of the things I love that she says so beautifully, and I agree with Katie 100%. If after this you want to know more information, this was a webinar really, really worth watching. Len, I think I did a couple times. But she quoted Dr. Wolfensberger saying, maintain curiosity and information gathering stance. When you spend time with somebody in the hospital, you will gather lots of information. And you can really maintain curiosity by continually asking questions, and by utilizing the information that you know in a diplomatic way. If you spend any time in the hospital, you'll also learn information you probably shouldn't know. People share rooms, you'll hear things in the hallway, and people are working really fast as they can. And so you really have to be diplomatic. And I think the other piece to remember is if you're somebody's supporter, and people don't like you. They don't like how you've handled them. They don't like how you've come at them. They don't like that maybe you're grumpy. They don't like those things. They may take it out on the person you're there supporting. So you have to be really careful to not become the problem you set out to solve, to only be enough a help and an advocate, but also to be really mindful of both the intended and the unintended consequences of your advocacy actions. So those were some pieces that we thought were really powerful.
And also this, people, as we've talked, and 2 weeks ago in the first session, and as we know deeply, as we've seen, as we've witnessed, as it happens, as it's experienced, people with disabilities are often seen in negative, stereotypical ways, such as burdens, objects of pity, eternal children, among many, many others. The emotional energy in other people in response to the person is often negative energy. So one way that advocates can offer protection is to become your loved one's public relations person at the hospital. This is what Leslie was alluding to. The public relations person at the hospital, help the staff understand who the person really is. Tell stories that show the person's commonalities with other people, tell stories about the good times, and broaden that the staff's view of the person who's there to receive medical care. Denise Quigley is a friend and colleague. The three of us used to work together at the Georgia Advocacy Office. She's a TASH member and a family member, and she has put together now 3 articles that are on TASH's website about keeping people with disabilities safe. So those can be downloaded for free and can be shared, and she has a lot of the tips as a family member, what she's thinking about, and as an attorney and an advocate for 20 years at the Georgia Advocacy Office, many, many years, with her experience providing protection and advocacy to folks. So there are some of them that we've mentioned. She talks about one thing that she says that we haven't mentioned yet is that if you're not allowed to stay, if you're not allowed to be in the room, that when you call, you know who to call. You've met someone, you figured out the shift changes, you figured out like who's the person who's going to, be able to talk with you and is kind. Ask that person to go into the room where your loved one is and have the conversation be on speakerphone, so that not only are you getting the information, but the loved one hears you as well. And so the communication is not kept from the person who's in the hospital, and the person also gets the benefit of hearing you and hearing your concern and hearing you check in on the person. So there are 3 of these articles that Denise has written on TASH's website.
And to add one thing, I just want to add one thing that Denise said that I thought was really powerful, and something I can imagine myself forgetting in that moment where I was worried about my loved one's pulse ox and I was racing to the hospital with somebody. But she also Denise writes some about comfort items and the idea that, hospitals are really unrestful places and very stressful, and to really think about what people need, favorite, blankets or textures or certain things that people might have with them that bring people comfort. I thought that was just a really, really solid point.
So we're going to open it up to questions after this. We just thought this is a good way to end. So we'll read. When this is over, may we never again take for granted a handshake with a stranger, full shelves at the store, conversations with neighbors, a crowded theater, Friday night out, the taste of communion, a routine checkup, the school rush each morning, coffee with a friend, the stadium roaring, each deep breath, a boring Tuesday, life itself. When this ends, and we find that we have become more like the people we wanted to be, we were called to be, we hope to be, and may we stay that way, better for each other because of the worst.
And I think we definitely want questions. But one thing we want to really encourage everybody on this call is that if we were doing this presentation pre-COVID, everything we've said today pretty much dovetails. I think some of the medical rationing stuff is less subtle. I think it always existed. And the no visitor policies weren't something that were really as common before COVID. I've heard of them a couple times, but not often. So, but beyond that, everything else is just solid advocacy practice and probably things you're very familiar with and things you just need to continue picking back up. And so we also want you to feel, we don't want you to get off this webinar and think, oh, that's what I should do. I can never do this, and this is so complicated. We outlined a lot of possible barriers and challenges in the material that may help you. It's unlikely that any one person would hit all of this, but we wanted, to give you a range of what's available and tell you that, you really have much of what you need.
And as we're going to check with Donald on questions, but there is a link that Leslie can drop in the chat box as well, which is just a Google form. It's very few questions, so that we can solicit your feedback and get your input on anything that you might have found helpful or anything that you think we should do differently next time. So we would really appreciate that.
I'm typing the link in the,
Thank you.
let's see.
I got it.
Oh, you've got it. You've got,
Yeah,
okay,
already.
sure. Okay, well, that's the main part of the presentation. We're ready for questions and answers now. If you have a question, if you roll your mouse over the Zoom window, the menu will slide up from the bottom, and you can, one of the options right about the center is the Q&A box. You can type your question in the Q&A box and we'll address it there. Or if you post it in the chat box, I'll read it from there as well. So Zoe, I see that you want to ask a question. Would you, we're just using the Q&A box. If you would put it there, I'll read it out loud for Katie and Leslie to address. Oh, let's see. I see somebody has one in the Q&A in the chat box. Thank you so much. My son is medically complex and trips to the hospital are very difficult in normal times. One of my worst fears has been what will happen if he needs medical care during the pandemic. The information you provided is incredibly helpful. Thank you. Oh, I'm sorry, that's a comment.
Thank you.
Let's see, Zoe, I'm going to unmute your microphone, Zoe, because I can't understand what you're saying, but so Zoe, if you, I think you default to mute, but if you roll your mouse over and unmute, you'll be able to ask your question.
Can you, hey, this is Zoe from Portland, Oregon. Can everyone hear me?
Yes, hello, Zoe.
Hi, so I have a question for Leslie.
Go for it. Go for it, Zoe.
It's so Leslie, you said for what was the first point you made? I didn't get it.
The first point, let me go back.
Yeah, I didn't get it.
The impact versus intent?
Mm-hmm. Yeah.
Okay, so you know how like somebody will
I didn't hear the question. Can you repeat it?
I'm sorry.
Could you just repeat the question, Liz? I didn't hear it.
Okay, her question was.
Can I introduce myself really quick?
Oh yeah.
Hi, this is Zoe from Portland, Oregon. My question is for Leslie and what's your name again?
Katie.
Katie.
Yes.
I have a question
Yes.
for both of you.
I see you. Do you see me?
No, I can't.
Huh. I'm here.
Donald, can you let me picture myself?
Oh, I actually,
if you can?
Actually, let's see, Luna.
That would be great.
No, I can't. Not in the webinar. Not in the webinar mode. Would you, Zoe? Would you just ask your question?
Sure. My question is, so you said, Leslie, that for the loved ones, I didn't get that point.
Is your question about that whole idea of impact versus intent?
Yes.
Okay, I can do that. So the idea is this. If you, a lot of people will do something discriminatory, like they'll say, we only have 10 ventilators, so we're going to give our 10 ventilators to people who are under the age of 50. And we don't intend, we love people over the age of 50. We don't intend to not give them medical treatment. We just think there's not very many ventilators, so we're going to let it happen, give the ventilators to people under the age of 50. So they have good intentions. Does that make sense? So the idea is we can't just look at the intentions, we have to look at the impact. The impact of that means that we value the life of people under the age of 50 more than we value the lives of people over the age of 50. So we decided across the board, for every single person over the age of 50, they can't have access to that kind of life-saving technology. So the idea is we can't look at intent, we have to look at the impact, because that's the whole civil rights movement. Because I've never met anybody who said in the civil rights movement, well, I really intended to be racist, or I intended to be ableist. They always say, I didn't intend to be that way. So you have to say, well, beyond your intentions, what is the impact of your actions? Does that help?
Could I just ask a clarifying question for Katie?
Yeah, go ahead, Zoe.
So Katie, you said basically, can you repeat what you just said? Because I was just so confused. Katie? Katie, can you hear me?
Katie, are you able to hear Zoe? No. Zoe, what point did you want her to repeat?
So I didn't get much of her points because I was spacing out. And I needed more clarifying questions. If she has a couple minutes, she can just introduce herself really quick.
Katie, would you maybe give us a repeat summary of what your presentation briefly, and then Zoe, this will be available as a recording. So if there was anything you missed, you can rewatch it when we post it then, and you can get the whole thing. Okay.
Okay. Thanks, Donald.
Sure. Can you hear me? Can you hear me?
Hold on. Yes, I can, Katie.
Hi. Can you hear me? Because I can give a recap if you can hear me.
Yeah.
Okay.
Go ahead.
So, excellent question, Zoe. So just to recap, what we talked about in this part 2, we started with the assumptions that get made about people with disabilities in our society. And then from those assumptions, what it is, because people believe that, how are people more vulnerable? What are some of the vulnerabilities that exist? Because people assume all these things that aren't true and that are harmful about people with disabilities. And then we walked through some of our ideas and shared some resources that we found to be helpful from other places around what folks can do right now to address some of the vulnerabilities. So what folks can do because people are more isolated, what folks can do, some ideas, some strategies when people are not as familiar with making their own decisions because other folks have made decisions for people possibly, or that folks are not getting information that is needed to understand the COVID-19 and to understand what's going on. So we shared some resources for self-advocates and the video about going to the doctor. And then we started talking specifically about medical safeguarding and what happens if a person needs to be in a hospital during this time, for COVID-19 or for something else, just if the person needs to be hospitalized, and what that person can do to prepare before that happens. So writing your story, getting some details together about who you are and what you need from folks, as well as having phone numbers and your support system easily accessible. So if the person does have to go to the hospital, that they would have the phone numbers and the names of folks that really know them and care about them, so that they can provide them to the doctors, the medical professionals. And then we shared a couple resources and a couple tips on what a person can do in the protector role in the hospital. So if you are standing beside someone who's receiving care in the hospital, what you can do as a protector, which doesn't have to be anything that's you don't already know how to do, to really be with the person, know who the person is, know what the person needs, and to act urgently to make sure that you get it, while being, kind and respectful of the current situation that all the medical professionals are into, because they are also at a lot of risk with the current pandemic. And I think that was a lot of what we went through and just the different resources. So thank you.
So another attendee asks, so then what can we expect from a medical situation that has limited resources? How are they expected to prioritize things?
So the answer to that question is obviously one that entire treatises and careers are made on, the idea of medical ethics. So how do we ration limited resources, which is really a consistent question that medical provision of services has addressed pre and down during COVID. But the answer from that question legally is that you cannot use disability within the rationing. The idea being if somebody has a disability, then they don't get access to the treatment. Additionally, this is more pointed, if there are certain types of allocation policies, like one would say, you can have a ventilator for this period of time, and if no great changes, improvements are made, then the ventilator could be reallocated to another person. That is a type of policy and protocol that hospitals have during this time. Then for a person with a disability, you can make a reasonable accommodation on that policy that they have more time to then gauge whether people have made improvement on the ventilator or not penalizing people for a pre-existing condition or a disability within that context. So, so the idea is that you can make the decision, you just can't make a discriminatory decision. That makes sense? I hope it does. It helps some. And I know there's another question.
Yeah, so somebody posed a question in the chat box. They say, thank you for this excellent and very informative presentation. I have noticed in the news there has not been much mention of people with disabilities, especially those living in ICFs, group homes, and institutions, and the rate of COVID-19 diagnosis and or deaths. Is this information being collected by the states?
That's a hard one.
You collect what you value.
Yeah, I think we're seeing, I mean, recently we saw in national news that the information that's being collected in our state may not be accurate. So I think that's the risk too. And I've read places where coroners are asked in other states not to put that the cause of death was COVID-19, that it was whatever the pre-existing condition was. So I don't know the information should be being collected by states, and specifically for people with disabilities, I don't know who's tracking that yet.
I don't know of a national repository tracking all the deaths of people that are subjected to congregated care across the nation. And if somebody else knows, please tell us, but I have not seen that. And we did a hefty amount of research for this. I don't think we missed it.
I know that the federal government has been promising for weeks now to pull out the data about congregate living centers.
But it's only going to be as accurate as the state's report.
Yeah, and they have continued to promise and not deliver. And I mean, the last I heard was maybe a week ago. They still hadn't been able to get their act together on that. Another attendee asks, are there any resources for guidelines for in-home direct care service providers we are concerned about caregivers that help with my son potentially bringing COVID into our home and possibly infecting him or one of us.
That is a valid concern. Yes, anybody who's coming to your home. A lot of folks that I know have asked support staff not to come right now, which might not be an option and puts the person also at risk. I mean, it's a hard decision to make. And what I've seen though is that the providers and then maybe the provider association in the state or the Department of Developmental Disabilities in the state are putting, some sort of suggestions and guidelines together. But I think it's ultimately left up to the provider agency, at least here, to, depending on what protective measures they have in place. And then that should ultimately be left up to the person who's receiving the services and the family members to determine whether or not what it is that they need so that you guys feel safe and that all parties are protected in that way when people are receiving in-home supports.
Like that, I was on a call with some providers recently and I heard some really great practices people are putting into place. So number one, where somebody may serve multiple people each week, they provide in-home supports to 3 different homes. Providers are rescheduling so people are only in one particular home, reducing just kind of like all of us, smallening up your circle and the amount of contacts you have, providing really high quality PPE, protective masks that are really comfortable that a person likes wearing when they're out and about or when they're inside, encouraging, social distancing and for people when they're not at work, making sure that there are really good hygiene practices within the house, seeing how many people, if you've got 3 people that work in your house, one of them does a lot of social distancing, 2 of them don't, maybe the third one is the person assigned to your house. And beyond the social distancing, the other piece is if you're narrowing the supports, making sure it's a really good match between the person receiving the supports and the person providing the supports. But we can also look for some more guidelines. But I think the guidelines are probably a lot like all of our guidelines.
We have 1 minute left. Do we have a last minute question or shall we wrap it up?
That's good timing for Friday afternoon before a holiday weekend. Thank you all for joining us.
And thank you, Tash, for having us. We really appreciate the opportunity and all we've learned from Tash and from y'all and the community. And, really, we want to keep all of ours safe and well.
Okay, yeah, thank the 2 of you very much for taking the time to, so much time to present this information to people. This is the second of our 2-part webinar, Safeguards Unprecedented Times Advocacy. Both episodes will be available as a recording on our YouTube channel or from our website. Just go to tash.org and click on the COVID-19 Response and Resources banner. Thank you, Katie Chandler and Leslie Lipson, for spending this time discussing the COVID-19 crisis and what we can do to reduce the danger for people with disabilities.
Yes. Thanks, guys. Stay safe.